In this video, I will talk about QRS complex. QRS complex represents ventricular depolarization, and is the combination of Q wave, an initial negative deflection, R wave, the positive upward deflection, and S wave, any negative deflection occurring after R wave. However, not all EKG leads contain all three waves. For example, normal QRS complex in V1 does not contain Q wave, but the combination of R and S wave is still termed as QRS complex for this lead. The duration of QRS complex is measured from the beginning of Q wave to the end of S wave. The duration of normal or narrow QRS complex is less than 100 milliseconds, shorter than 2½ small squares. Narrow QRS complexes are supraventricular in origin. A duration of 110 milliseconds is sometimes observed in healthy individuals. A QRS duration more than 120 milliseconds or 3 small squares is considered broad and abnormal. Broad QRS complexes may be either ventricular in origin, or due to aberrant conduction of supraventricular complexes, for example, bundle branch blocks. Sometimes, both narrow and broad QRS complexes may be observed in EKG, for example, ventricular bigeminy. In this EKG, narrow complexes are sinus in origin and broad complexes are ventricular. The main features to consider QRS complex morphology are the duration of the complexes, narrow versus broad, and voltage or height of the complexes. Narrow QRS complexes arise from three main origins: from sinoatrial node, with a normal P wave, elsewhere from the atria, in which abnormal P wave, flutter wave or fibrillatory wave can be observed, and AV node or AV junction, in which P wave is not visible or abnormal with PR interval less than 120 milliseconds. QRS duration more than 120 milliseconds is required for the diagnosis of bundle branch blocks or ventricular rhythm. Differential diagnosis of broad complex tachycardia includes ventricular tachycardia, or supraventricular origin with aberrant conduction, secondary to bundle branch blocks, ventricular pacing, metabolic disturbances that slow supraventricular action, potential propagation such as hyperkalemia, poisoning with sodium channel blocking agents with tricyclic antidepressants, pre-excitation syndromes such as Wolff-Parkinson-White syndrome. Differentiation between ventricular complexes and SVT with aberrant conduction may be difficult. In general, aberrant conduction of supraventricular rhythms can usually be identified by the presence of atrial activity, such as P waves, flutter waves or fibrillatory waves. However, aberrantly conducted junctional complexes may appear identical to ventricular complexes, because both produce broad QRS with no atrial activity. Sustained ventricular tachycardia can cause severe hypotension, and can thus be life-threatening. Wide complex tachycardias should be presumed to be VT until proven otherwise. Difference between VT and SVT with aberrancy is explained detail in another video. Other causes of broad QRS complex can be recognized by pattern recognition. Left bundle branch block is characterized by a deep and broad S wave in V1, W-shaped QRS complex, broad and notched R wave, M-shaped complex and absent Q waves in V5 and V6. In right bundle branch block, RSR prime pattern in V1 or M-shaped QRS complex, and deep slurred S waves or W-shaped complex in V5 and V6 can be observed. EKG changes in hyperkalemia include tall and tented T waves. Tricyclic poisoning is associated with deep and slurred S wave in leads 1 in AVL, and tall R wave more than 3 mm in AVR. Wolff-Parkinson-White syndrome is characterized by a short PR interval and delta waves. Visible pacing spikes can be observed in ventricular pacing. Hypothermia is associated with bradycardia, long QT interval, Osborn waves and shivering artifacts. High QRS voltage is often seen in left ventricular hypertrophy, but may also be a normal finding in slim or athletic individuals. There are multiple voltage criteria for left ventricular hypertrophy. The Sokolow-Lyon criteria is commonly used. In left ventricular hypertrophy, the sum of the depth of S wave in V1, and the height of tallest R wave in V5 or V6 is greater than 35 mm. The QRS complex is said to be low voltage, when the amplitudes of all QRS complexes in limb leads are shorter than 5 mm, or the amplitudes in precordial leads are shorter than 10 mm. The most important cause in low-voltage QRS complex is massive pericardial effusion, in which the alternating QRS voltage may be observed, due to the heart swinging back and forth within a large fluid-filled pericardium. Low-voltage QRS complex can also be seen in obese person, COPD with hyperinflation, generalized edema, infiltrative cardiomyopathy like amyloid cardiomyopathy, myocarditis, hypothyroidism, and prior myocardial infarction. I hope you enjoy this video. Thank you for watching this video. Stay safe and healthy.